Thanks for your patience. You've seen the title for long enough. I'm not going to belabor that. And these are my disclosures. The only relevant ones are that I have started a company for this technology, and I'm also involved with PureTech's LYT-100 trial. A lot of this work has taken many years to get to, and multiple sources have supported this research. And so it really comes down to, so what happens when there's lymphatic injury? All of us, I think, know that you have one of two options if your lymphatics are injured. You either don't get disease, approximately 70% of the time, for a full axillary lymphadenectomy, or you get disease. And basically, in my fairly simple analysis of this, you either have compensatory lymphangiogenesis, and you don't get disease, or you don't knock out enough lymphatic channels. And then the other scenario is you've destroyed all the lymphatics and you simply can't regenerate them, and of course you go to lymphedema. And this is illustrated nicely in the book by Chang, and Patel, where, at least in this scenario, you're regenerating lymphatics in green, and therefore you don't have lymphedema. And in this unfortunate situation with a very large lymphodematous arm, the channels just are not reconnected and you have disease. And so this also illustrates the same phenomenon. And this arm proximal here and this arm distal matches the orientation of these lymphatic valves. And so on the left you see normal flow. And as all of us are aware, lymphatic flow is mainly unidirectional due to the fact that lymphatics have valves. That being said, we were talking earlier at lunch that although there's valves, since the lymphatic flow goes against gravity, there's a little bit of oscillatory flow just because that's the nature of how things work with gravity and a system without muscular tone. In the setting where you have obstruction proximally like you would in either a groin or axillary dissection, what happens is you have dilation due to the obstructive proximal flow. Then you have reversal of flow and sort of destruction of the architecture of the valves due to this flow problem. And then eventually, this is part of how lymphedema develops. And while we have discussed lymphedema treatment from many of the prior speakers, there are non-surgical and surgical benefits and things like that, ranging from symptomatic relief, improving symptoms, decreasing cellulitis, reducing limb size, improving quality of life. That being said, there is no cure, and I think Ed Chang mentioned there's no cure. I think we'd all agree there's no cure to lymphedema once it's already established. And therefore, since there's no cure, really our best opportunity as people that are invested in this disease is to try and prevent it. Just like other forms of medical disease, heart disease, colorectal disease, all of medical problems are better served by preventing them before they actually are manifest. And so my group has thought about this, and really the best bet is to try and mitigate lymphedema, at least from our arsenal of tools, to try and induce the body to regenerate lymphatics on its own, akin to what BioBridge does. It's just providing a scaffold for our body to try and regenerate on its own. And why is this useful? Mostly because although lymphedema results from surgical lymphatic disruption and obstructed proximal lymph fluid flow, microsurgical expertise is limited. While there's a lot of people doing it more and more, it certainly does not meet the need of people that are inflicted with lymph node disease. In the community, those patients don't have access to what our group provides, and microsurgical expertise is limited by time and human hands. And so to try and affect humankind in a broader way, the hypothesis is, can we prevent lymphedema by stimulating lymphangiogenesis and lymphatic regeneration, just by having the body do it as opposed to having our very skilled hands doing it? Although we like to do it, it just would be better if there was a simpler way. Everything we can do to try and innovate ourselves out of having a job is probably a good thing for health. And so my group has spent over the past decade sort of looking for some way to do this via some sort of lymphatic growth factor. And these are the ideal characteristics. They should be non-toxic, biocompatible, biodegradable. They should be specific in that they should not have off-target effects. They should act efficiently at the tissue bed of of interest, that being lymphatic injury. The action should be consistent. It should be easily and predictably metabolized and inexpensive. And so these are the ideal characteristics. Hard to find, though, I'd say. And the thing is, there already are a lot of candidates. Science has demonstrated that there's many growth factors and many pathways to get to lymphatic regeneration or lymphangiogenesis. That being said, they're not all specific. And so this is the cast of characters. I'm not going to run through all this alphabet soup, but many of these names are familiar, including the most prominent vascular endothelial growth factor C, but there's a whole host of other things, including fibroblast growth factor, platelet-derived growth factor, and others that actually do stimulate lymphatic growth. That being said, this whole arm over here, while they stimulate lymphatic growth, they also stimulate growth of other cells. So this is not specific enough. And then these others, they're more specific in that they won't stimulate a fibroblast. They'll stimulate all endothelial cells. The thing is, endothelial cells make up not only lymphatic endothelial cells, but blood endothelial cells. And so these other ones that are X'd out, including the angiopotens and VEGF-A, produce blood vessel growth in addition to lymphatic growth. So we're left with these fairly limited VEGF-C and D ligands to do this. And so it's quite powerful, quite specific, was discovered in 1997 and published in Science. And since then, over 1,200 citations for VEGF-C and lymphangiogenosis. For sure, this is sort of the most, the darling molecule for this strategy. And a number of authors, names familiar to this group, demonstrated that you can achieve, you can make new lymphatic vessels with gene therapy with minimal blood vessel side effects, meaning you can just make lymphatic vessels and not blood vessels using VEGF-C. You can prove that it actually augments postnatal lymphangiogenesis and can stop secondary lymphedema. And then this was done in large animals, and so quite convincing. Got to the point where Kerry Alitalo collaborated with a company to develop an adenovirus to try and prevent or cure lymphedema based on expression of VEGF-C. And this was the person that sort of discovered VEGF-C. And this went through phase 1 and phase 2. And unfortunately, in March of 2021, they demonstrated that while they tried and they didn't show much toxicity from their adenoviral VEGF-C compound, they stopped, mostly because they couldn't tell if it was working very well. I'd have to dig in further. I unfortunately think it was probably not designed optimally, but for a variety of reasons, that company pulled the plug, and this is no longer in clinical trial. In addition, when I looked at VEGF-C, while it's certainly the molecule involved in lymphangiogenesis, it has risks. Think about lymphatics. What do? They help, they're all over the body. And the problem is, as we know and our oncology colleagues know, they sample lymphatics and they look at lymphatics in cancer therapy because this is how cancer spreads. And so if you're going to be using a vascular endothelial promoter or growth factor, obviously the risk is that you can prevent micrometastasis, and this also is challenging. And this in Nature Medicine was published over a decade ago, and in nude mice, they showed that human cancer could spread in the presence of VEGF-C. And so there must be other alternatives, like everything we do in terms of reconstructive microsurgery and surgery. Don't put all your eggs in one basket, have a backup plan. And so certainly that was what our group was interested in. There's a number of other opportunities to stimulate lymphatic growth, and many of them, again, more alphabet soup, are listed here. I'm not going to belabor all these because it's many years of scientific work. But our group looked at the fact that, well, lymphatic vessels are part of the blood vessel system. They're intimately related to both arterial system and the veins, and they're just intertwined between them. So they're definitely sisters or cousins. And so we looked at an opportunity to examine a compound called retinoic acids. They're vitamin A derivatives. And the reason we got interested was because there was controversy. And whenever I see controversy, I see opportunity. And basically we found, at least here on the left, that retinoid agonists can promote angiogenesis or blood angiogenesis. Here again, the retinoic acids are inducing angiogenesis, and this means blood vessel angiogenesis via retinoic acid receptor, which is the native receptor for retinoids, and using vascular endothelial growth factor. And here they're talking about VEGF-A. On the other hand, you've got this other group of literature showing that retinoic acid inhibits angiogenesis in this paper. And again, acyclic retinoids inhibit angiogenesis. And so this is controversy. And so we dug into this a little bit deeper. And we thought, well, we didn't actually see any literature on what retinoids did for lymphatic endothelial cells, which are distinctly different from blood endothelial cells. And we tested this hypothesis in the early second decade of the 2000s. And so we tested a number of different retinoids, all of which are FDA-approved compounds, as mentioned earlier, used for dermatologic diseases and some skin cancers. And when we isolated lymphatic endothelial cells and then subjected them to various retinoids, we found that it stimulated them to grow, which we thought was promising. Then we took 9-cis retinoic acid, which was favorable mostly because we found that it was dose dependent. The more we gave of it, the more the cells grew. And so we pushed that a little bit further and looked at it. And also we chose it because it was the least teratogenic of the retinoids. No drug is perfect. The main liability of retinoic acids is that they are a teratogen. And so if you're going to take them, you need at minimum 2 forms of birth control if you're a childbearing woman. And so ultimately, a battery of tests were done, and this was a culmination of a lot of work by my scientific partner, Wong, and myself, and this was published in 2012. And this showed that this interesting molecule, 9-cis retinoic acid, was favorable. And we found that it could promote these LECs, or lymphatic endothelial cells, to migrate, and so that was good. So in addition to proliferating, we found that it could cause these cells to move across the tissue culture dish, which is important for growing new lymphatics. We also have this 3D matrix matrigel, where if you put the cells in, and then you can either provide a vehicle control or no drug on the left, and then in the same amount of cells put in 9-cis retinoic acid, you can visually see that it forms this lattice or matrix that's the in vitro marker of lymphangiogenesis. And this is measured by the number of cords that they make, and it's visually fairly obvious here and quantitated on the right. And so that was promising. And then we took this compound and said, well, great, it works in a tissue culture dish. Does it work in animals? And so we did that and loaded matrigels and then put them in these transgenic mice that we made. And these mice basically show us where lymphatics are because the transcription factor PROX1, which is highly expressed in lymphatic endothelial cells, was hooked up to something called green fluorescent protein. And basically anywhere where you see lymphatics, they're green. And so when we did this, we put this matrigel that had nothing in it, put it in the mouse, and then we loaded a matrigel with 9-cis retinoic acid, and we found a pretty robust tubule formation that were PROX1, which means they're lymphatics. Then we took that one step further and said, well, that was a nice in vivo study, but let's actually make a real lymphedema model in an animal and see if it works. And so this was our animal, which we iterated from a number of other prior authors. We did a complete lymphadenectomy by highlighting the lymphatics with blue dye, and then did a circumferential dermal destructive procedure because there are actually lymphatics in the dermis. And so we obliterated every possible lymphatic in this animal. And then if you do that, you can see that their paw gets lymphedema. It stays there for over 90 days. In addition to just surgical edema, it is true animal lymphedema, whereas the contralateral paw is quite slender. And so we basically did our animal clinical trial, and I neglected to mention that animal model incorporates radiation, which is common for lymphedema. And basically, we tested whether 9-cis retinoic acid could prevent lymphedema, and and this on the left shows the time sequence with the numbers representing the days after injury. And on the left, you have animals as a function of time, increasing time going down on the slide. after lymphatic injury. And these animals get a vehicle control, meaning they're injected with the carrier for retinoic acid, but not retinoic acid. And so you can see that the paw develops and gets thicker over time and has paw lymphedema. Whereas the cohort of animals that had the same lymphatic destructive injury, those that got retinoic acid on a daily regimen, they actually never even get any significant surgical edema, which is interesting, and they also never develop lymphedema. And so this is the same data shown with the actual data points distributed. You can see that if you perform lymphatic injury in these animals, there's a spread of percent change of limb volume, and this is pretty normal. That being said, if you do the same thing to a parallel group of animals and give them retinoic acid, it's a very, very tight bar where really they just don't get any sort of swelling. And you can see that here expressed as a graph showing percent change in limb volume on the y-axis and time on the x-axis. I won't belabor this more, but I can talk more about it if other people are interested. And then we analyzed this, and we saw that with 9-cis-retinoic acid, you can see a real change when you take these paws out and analyze them. On the left, this is the control animal that has just a vehicle control, meaning they're injected with actually some form of oil that does not have retinoic acid in it. And those animals that were treated, you see that the lymphatics actually have a larger caliber. And then there's also spots where there's more lit up or more intense green, and these actually are the valves in the lymphatics. And then if you do standard lymphatic analysis, you can see that they're significantly different in terms of the total length of the lymphatics and the total density. So that's nice. To try and push this further, we sort of asked, well, how real is this? There's always a doubter in the lab, and they're like, well, does this really work, Dr. Wong? And so what we did was now we challenged ourselves by, well, let's give this to animals in a different form and ask, well, if you only give 7 days worth of the drug or 14 days worth of the drug, is there a difference? Mostly because all of the prior studies were based and demonstrated on a 6-week treatment course, meaning after 6 weeks, they never get lymphedema. And so what happens if you only give them 1 week's worth or 2 weeks worth? Or delay means, let's just say you forget to give the animals a drug, meaning let's say you did surgery and a week later you gave them drug. And what's the difference of starting therapy at the time of injury or delaying it by a week? And you can see that here. And all the animals at day 0 pretty much look the same. Some have a different amount of blue dye there, but that's really not that relevant. And here, 6 weeks later, if you get vehicle control, meaning no drug, you have a swollen tail, if you're a mouse. If you get 7 days worth of drug, you have a slightly less swollen tail. If you get 2 weeks, you have a pretty almost normal looking tail, but not as normal if you get it for the full 6 weeks. And if you wait a week and then get therapy, again, even though you only have 1 week less therapy than this 45-day treatment group, you're still not normal, indicating that you sort of need this drug pretty much at the time of injury for it to help. And so that was helpful. So these are all a 42-day or 6-week time point, and that's the different effect. I mean, if we delayed it for 2 weeks, I suspect we would have had a different effect, but we just had to choose some arbitrary time points. And this is a graphical representation of that, where you look at the density of the lymphatic microvessels, and you would expect that without retinoic acid therapy, it's going to be the lowest density, and that's what you see on the black bar. And the more duration of therapy you get, the higher density of microvessels you get at the site of lymphatic injury, with the most being associated with the full treatment course of 45 days. And obviously the less you get, the less density of microvessels you get. And here's that delay phenomenon where you delay it by 1 week, but then you still give it 5 weeks of therapy. It's just not as good. And this pretty much mirrors the pictures that you saw previously. And then I brought this up earlier because we talked about this trauma or inflammation effect, lymphangiogenesis. And there's a lot of literature besides this data that demonstrates that some level of inflammation is necessary for lymphangiogenesis. And here we took the same group of animals where we treated them with nothing, or 7 days worth of drug, or 14 days worth of drug, or 45 days worth of drug, or this delay group. And we thought, well, let's look at a place away from their tail or wherever we injured them. And so we decided to look very far away, and we looked at the ear. And the ears do have lymphatics in them. There are actually some robust rabbit models for lymphedema. And so there are lymphatics in the dermis of the ear of the mouse. And we looked at all these, and we subjected them to the same lymphatic assays that we did for our other earlier studies. No significant difference amongst any of these groups at the ear, suggesting that if you're a quiescent lymphatic, retinoic acid does really nothing for you. Probably good, I think. And so, why does 9-cis-retinoic acid work? And so, basically, back in 2012 in our circulation paper, we looked at the most likely candidates of why this might be working. We looked at the vascular endothelial growth factor family using some specific inhibitors, and found that actually didn't seem to need VEGF-C according to those sort of rudimentary analyses. We're pushing that further because we're not quite convinced. But when we looked at another likely suspect, that being the fibroblast growth factor receptor family, we found curiously that if you look at this, and this is an RT-PCR or a measure of transcriptional activation of these receptors, that if you look at each of these receptor isoforms, and GAPDH is a control showing that they're all loaded with the same amount of material, that if you're looking at FGF receptor 1 over time, sure, retinoic acid seems to do very little. Maybe there's a little bit up after 24 hours. FGFR2, nothing's going on here. However, FGFR3, at 6 hours, you have a huge spike of expression, and then it kind of goes back down. We found that very curious. We found that FGFR4 does something similar, but not quite as much of a robust delta. And so we focused in on FGFR3 because we just found that maybe this is the sort of activation that's sort of kicking off the cascade for lymphangiogenesis. And this is how that receptor works. It's a traditional receptor tyrosine kinase transmembrane, where basically the ligand, being FGF, binds to the receptor, and then it causes these receptors to come together at the membrane and then do some signaling downstream. And so what we did was, well, if FGFR3 is important, what would happen if you block it? And so we found some papers showing that you can block FGFR3 using a small peptide, 12 amino acids, and the sequence is here. And if you give cells these sequence, actually you can pretty much block specifically FGFR3 signaling. And so we did that in our system, and basically we found that if you give this peptide, it's called P3, if you give it to the cells, and then, well, let me start 1 second. Here we wanted to confirm the prior data. So the prior data was sort of a rudimentary RT-PCR. This was a quantitative RT-PCR where we could actually see the percent change. And again, if you give 9-cis-retinoic acid to cells in vitro, again, you see the same spike at 6 hours, but it's a 3,000% upregulation, which in biology is pretty unique. And so we confirmed that actually it happened. And then using this P3, we asked, well, if you block FGFR3 and still give the ligand, which is FGF, will you see activation of fibroblast growth factor receptor 3? That's and activation means phosphorylation. And here we showed that if you give the ligand plus P3, you pretty much block activation of this receptor. That being said, if you give P3 alone, or SC, which is a scrambled peptide, or the FGF2 plus a scrambled peptide, you still have activation of it. And so this sort of proves that when you give the ligand for this receptor plus this P3 inhibitor, it does block it down pretty well. And so what we did was we gave this to animals, and we did what's called a tracheal ring assay. And so these are the trachea of the animals. And essentially, if you give nothing, and so it's probably easiest to look at this far right, this 10x column here. Vehicle control, if you look at the trachea, you give nothing, you sort of don't see much green, which is no lymphatics. If you give 9-cis-retinoic acid, you see green tubules forming across the trachea, indicative of some in vivo lymphangiogenesis. If you give the 9-cis-retinoic acid plus this scramble peptide, which is the same amino acid, it's still 12 peptides, but it's the wrong sequence, you still see some green going into the middle, showing that the 9-cis-retinoic acid is working. That being said, if you give the 9-cis-retinoic acid plus the specific P3 inhibitor, basically it looks the same as giving nothing, indicating that if you block FGFR3, 9-cis doesn't work. So, in our opinion, relatively convincing that at least in this specific scenario, 9-cis-retinoic acid does not induce lymphangiogenesis in an animal if you specifically block FGFR3. And so that was compelling and most likely part of it, and that's an ongoing study in our laboratory. To get to some translational work, we thought the way we normally give this is either orally, you can give it by mouth to these animals. We also, I tortured some prior research fellows by having them inject the animals intraperitoneally every day for 42 days. Very loyal fellows. And that being said, that was not necessary. And if you're a mouse, you don't like it. If you're a human, you definitely don't like it. And we thought is there a simpler way? Is there a way to make it simple? Is there a way to increase compliance? Because let's just think translationally. And if we had a patient take a drug for 6 weeks for a disease they don't have, is that going to happen, right? I don't even take my vitamins. So the compliance could be poor, right? They don't know if they're going to get lymphedema or not. They'll be like, I'm not going to take this pill, even though Dr. Wong says it's good. Forget it. Let's take that out of the equation and put it in the hand of the surgeon who actually knows and saw that lymphatic injury and can make the decision. Meaning, if the lymphatic injury is bad enough, and we talked about it earlier, we could do imaging to see if it's bad enough. Meaning, if there's no flow through, then you would say, okay, let's either do ILR or pop in this slow release form of 9-cis-retinoic acid and see if it works. And basically, we did this in rats. Essentially, we did rat lymphadenectomy, complete harvesting and destruction of lymphatic pathway, and put in this pill. And the pill is a slow release version of 9-cis-retinoic acid made by an outsourced company. And it either has nothing in it or it has retinoic acid, and it releases it at a rate of 0.08 milligrams per kilogram per day for 6 weeks, and then it stops. And so basically we did that, and you can see the blue is the placebo group, and we're measuring change in size of the limb. And the placebo group has a predictable increase in limb size to about between 10 and 15%. And the animals that got the treatment, or the one with the 9-cis-retinoic acid, yes, they do have some increase in limb size from the surgical edema, but basically over time, they literally have no change in limb size, and this is a very, very significant difference. 10% in these animals, but still quite significant from a statistical standpoint, demonstrating that literally a simple maneuver of putting in a slow-release drug into a lymphatic injury site has a potential clinical utility. And so what else are we doing? Some may ask, well, why did you focus on 9-cis-retinoic acid? I get this question all the time. There's actually 4 first-generation retinoids, 2 second-generation retinoids, and 3 third-generation retinoids. Great question. You know what? We focused on 9-cis because from our readings, it had a little bit less teratogenicity. That being said, these other retinoids, which all of you know, tretinoin, isotretinoin, we use this for acne and other things. We're testing the others. Our early data shows that, at least in vitro, all trans and 13-cis pretty much do the same thing as 9-cis. We have not tested it in vivo, and we're on a path to do that. We tested bexarotene because that is interesting. It gets very, very receptor biology, but that's a specific, it's called a retinoid X receptor specific ligand. And so the retinoids bind to either something called RAR, which is retinoic acid receptor, or RXR, which is retinoid X retinoid X receptor. This happens, 9-cis tends to have a preference for RXR. It's the naturally occurring ligand for RXR. Bexarotene is only RXR, and so we thought that might help. It actually may not. There may be need to be a little bit of binding to both, and we're still trying to sort this out. That being said, there's hope, meaning it doesn't have to be the specific derivative. And the other reason that's good is because 9-cis is approved topically here in the US, but actually the oral form is only approved in Canada and Mexico and the UK. Actually, when we did our studies, we had to order the drug from Canada. I wrote a prescription for one of my students, and we ordered it, and we crushed it up and gave it to the animals because you can't buy the oral form in the US. And so when I talked to one of our pharmacy faculty about how to get around this, they said, well, what about the other retinoic acids? And I'm like, that's a good point. So that's why we're testing these others, because tretinoin and isotretinoin, I could write Young a prescription today, and we could all take it tomorrow. So, but we do need to do the animal studies and make sure it's doing the same thing. Maybe it does something different. We simply don't know. Why are all these different drugs? I mean, every company sells a different retinoid, and they have slightly different indications. So we have to sort this out. The other thing is, although I do believe retinoids are pro-differentiation, they don't have any gross stimulatory effects in general. I do show that they are stimulatory for lymphatic endothelial cells. And so the other thing I really want to do before we start doing this in people is to guarantee and make sure these have no stimulatory effect on cancer cells, because any patient that would need this is likely to be a cancer patient. And so before I throw a big slow release nugget of compound into someone's axilla who just had breast cancer removed, I want to be really darn sure that this is not going to give them cancer. And so many of you know I just moved to City of Hope, and this is a cancer center, and literally I get this email about this NCI 60 high throughput screen, and so now we're going to screen 60 different kinds of cancers against actually 4 different retinoic acids, and to prove beyond a shadow of doubt that they don't do anything. Or maybe in certain cancer types they do something. We just need to know. I'm pretty sure it doesn't do anything in breast, but we're going to look at 60 different cancer types and have some real data to guide us. And then lastly, this is very molecular. It has to do with, how does this work mechanistically? One of my students who will be applying in plastic surgery this year, Cynthia Sung, brilliant woman, doing her Dean's Fellowship work in our lab. She's finishing up this work on using a tissue-specific, lymphatic-specific knockout of this RXR receptor. And this is beautiful work showing that if she knocks out, which she already did, she knocked out the RXR receptor specifically only in lymphatic endothelial cells using a system called Crelox. It's a common targeting technique that is used for this. And you have to do that because if you knock out RXR in all the cells, animal's dead. And so you have to do that once the animal is formed. You give them it's tied to estrogen. You give them tamoxifen. It knocks them out this postnatally. And then basically you show that if you don't have this and you give these animals 9-cis, nothing works. And demonstrating that at least in lymphatic endothelial cells, this is essential for lymphangiogenesis and for retinoic acid to help post-surgical lymphedema. Looks like I may be getting out of time. But anyway, we're pushing this forward. This is protected by a patent at USC. And really the most important slide is, what's the future? Obviously, I put retinoic acid therapy at the top, not because it's there, it's just because I have the opportunity to put it at the top for right now. Basically, I think that it's safe. It provides action at the cellular level. These are microlymphatics that no microsurgeon can put together. Only our bodies can do this at the cellular level. And so this is going to act at the dermal microlymphatic level. Couple this with immediate lymphatic reconstruction, which shunts relatively large lymphatics. Yes, they're sub-millimeter, and it's hard for even the best of the super microsurgeons. But these are large relative to these ones that retinoic acid can work on. I'm not proposing that RA can make these bigger ones. So I think we probably have to do both for the best action. That being said, each on its own probably will be good, meaning we're going to see studies showing that immediate LVA will be good. I predict one day we'll see some studies showing that retinoic acid will help too. But if you combine both, they simply worked on lymphatic structures that are orders of magnitude different. And I think if you couple them, it's going to be better. And you know, in honor of our sponsor, Fiberline, you know, BioBridge is going to have a different mechanism, which I think is, you know, may have some overlap, but be different. And if you put this other biologic next to things, you're going to continue to improve and iterate and really make this a non-disease. And so I think that's the future, and that's the hope. So thank you.